This video discusses elderly influenza vaccination indications, preformed toxin-induced food poisoning, signs and symptoms of Group A streptococcal pharyngitis, antimicrobial for atypical pneumonia, and diagnosis of bacterial pneumonia.
Multiple choice question number 1.
You oversee the medical care of elderly people who live in nursing homes. An influenza A epidemic has just broken out in the area, and some of the patients have shown signs similar to the influenza. The influenza vaccine has not been administered to a single resident of the care home. What is the most suitable line of action? A. Give the influenza vaccine to all residents who do not have a contraindication to the vaccine. B. Give the influenza vaccine to all residents who do not have a contraindication to the vaccine. Also give oseltamivir for 2 weeks to all residents. C. Give amantadine alone to all residents. D. Give azithromycin to all residents to prevent influenza-associated pneumonia. Or E. Do not give any prophylactic regimen, but treat with oseltamivir if a clinical outbreak should occur.
Answer is B. Give the influenza vaccine to all eligible residents and also give oseltamivir prophylaxis for 2 weeks. This protects residents in the short term via antiviral prophylaxis and offers longer-term protection via vaccination. Other options. Vaccination alone during an active outbreak is insufficient because protection takes about 2 weeks to develop. Amantadine is not recommended due to high resistance rates and limited efficacy against current influenza A strains. Azithromycin does not prevent influenza or associated pneumonia. Early prophylaxis in an outbreak setting reduces transmission and complications.
Multiple choice question number 2.
An unexpected attack of nausea, vomiting, and stomach cramping brings a family of 4 to the emergency room. There's no sign of diarrhea or fever in them. They had grilled meats, fried rice, and spiced veggies at a roadside diner, and these symptoms began 4 hours later. In your opinion, what could be the root of the illness? A. Preformed toxin ingestion. B. Bacterial invasion of stomach and small intestine wall. C. Proliferation of ingested bacteria with subsequent production of toxin active against small bowel mucosal cells. D. Bacterial infiltration of the colonic wall. E. The pathogen's proliferation in the proximal small intestine resulted in secondary malabsorption.
The option A is correct. Food poisoning induced by preformed toxins like Staphylococcus aureus or Bacillus cereus, which can contaminate cooked foods at unsafe temperatures, typically cause symptoms within hours of eating. Toxins cause nausea, vomiting, and cramping swiftly without bacterial invasion or multiplication. Gut bacteria or toxins usually take longer to induce symptoms. For example, Salmonella or E. coli cause diarrhea and fever after 6+ hours. As there is no diarrhea or fever and symptoms developed quickly, bacterial invasion of the stomach or intestines, options B, C, D, is unlikely. Option E, pathogens overgrowth-induced secondary malabsorption would create chronic symptoms.
Multiple choice question number 3.
A 20-year-old lady reports having a sore throat for the past 2 days. In terms of symptoms and indicators, which of the following best describes Group A streptococcal pharyngitis? A. Fever, anorexia, dysphagia, and hoarseness. B. Fever, runny nose, cough, myalgia, and poor appetite. C. Fever, no cough, tonsillar exudates, and tender anterior cervical lymphadenopathy. D. Fever, cough, pharyngeal erythema, and dysphagia. E. Fever, trismus, dysphagia, and neck swelling.
Answer is C. Group A streptococcal pharyngitis is more common in children, but accounts for only about 10% of adult pharyngitis cases. The center criteria, fever, absence of cough, tonsillar exudates, and tender anterior cervical lymph nodes, help identify patients at risk. Those with 2 or 3 criteria should have a rapid strep test or throat culture before antibiotics. If all 4 criteria are present, empirical treatment can be considered while awaiting confirmation. Penicillin for 10 days is the first-line treatment. Azithromycin for 5 days is used if penicillin allergy exists. Symptoms like trismus, hoarseness, or neck swelling suggest more severe infections. Runny nose, cough, and muscle aches point towards viral causes.
Multiple choice question number 4.
A 30-year-old male arrives at the emergency department with complaints of fever, shortness of breath, a dry cough, and diarrhea that started 3 days after an upper respiratory tract infection. On examination, he has a temperature of 40.5 degrees Celsius, a respiratory rate of 20 breaths per minute, and bibasal inspiratory crackles heard on chest auscultation. A chest X-ray reveals bilateral interstitial infiltrates. Which of the following should be the initial antimicrobial therapy? A. Penicillin. B. Azithromycin. C. Ciprofloxacin. D. High-dose trimethoprim sulfamethoxazole. E. Amoxicillin clavulotic acid.
Azithromycin is the preferred treatment because it effectively targets all major atypical pathogens responsible for pneumonia, including Legionella species, Mycoplasma pneumoniae, and Chlamydia species. It is also generally well tolerated by patients. Other antibiotics do not provide such broad coverage against these atypical organisms. Early initiation of an antibiotic with intracellular activity is crucial, as nearly half of atypical pneumonia cases may not yield a detectable organism in sputum or blood cultures. When diagnostic tools like PCR or gram staining fail to identify a specific pathogen, empirical treatment for community-acquired pneumonia should include coverage for atypical bacteria. Macrolides, such as azithromycin, remain the cornerstone of therapy for atypical pneumonia and also provide additional protection against Streptococcus pneumoniae.
Multiple choice question number 5.
After a week of dry coughing and shortness of breath, a 78-year-old woman goes to the emergency room in the middle of December. She feels chilly, but her temperature is normal. She mentions neither chest pain nor sick contacts. She has up-to-date vaccinations for everything from the flu to pneumococcal disease. Diabetes and hypertension are 2 of her health issues. She takes aspirin, insulin, lisinopril, metoprolol, and hydrochlorothiazide as prescribed. Upon examination, she does not seem to be wheezing and has basal rales. The cardiologist found regular heart rhythms during the assessment without gallops. She has a grade of 1+ for lower limb edema. There is no apparent banding and the platelet count in the blood is 12,000 microliters. Both her renal function tests and liver enzyme testing came back normal. The chest X-ray shows basal opacities on both sides. Which of these statements is accurate about the steps needed to confirm a pneumonia diagnosis? A. High B-natriuretic peptide level. B. High procalcitonin level. C. High D-dimer level. D. High troponin level. E. Low C-reactive protein.
In bacterial infections, such as pneumonia, procalcitonin rises unlike in viruses or other microbes. Many cells create procalcitonin, a precursor to calcitonin, during inflammation, especially in bacterial pneumonia. Bacterial pneumonia may raise procalcitonin levels hours later. It may be unaffected by empyema and lung abscess bacteria. Ventricular D-natriuretic peptide release increases in heart failure patients. D-dimer, a coagulation protein, is increased in patients with deep vein thrombosis or pulmonary embolism. After cardiac cell injury, troponin I levels rise in the bloodstream, indicating myocardial infarction. C-reactive protein measures inflammation sensitively yet non-specifically. It increases in inflammatory situations regardless of cause.